Thank you for inviting me to participate today. I'm truly, truly grateful to be able to share on behalf of CRAN, or the Colorectal Cancer Resource and Action Network, and the Conference Board of Canada, the findings from our recent Comprehensive Genomic Profiling, or CGP, cost and benefit analysis study, which we commissioned through the Conference Board of Canada. And for those of you who may not necessarily be familiar with the Conference Board of Canada, they're essentially a research-based company who generate economic data in Canada to drive positive change through innovation and evidence-based ideas. And we truly feel quite privileged to have been able to work with them. So in terms of the very ambitious agenda to which I'm going to be adhering to, I'd like to speak briefly to who we are at CRAN, just one slide, why we dedicated a mandate to advancing biomarker testing, speak to the work and efforts that led to the CGP cost-benefit analysis study, and then I'll get right into the compelling CGP study findings that were recently issued. So who are we at the Colorectal Cancer Resource and Action Network, or just simply CRAN? We originated as a grassroots colorectal cancer information and support group back in August of 2006. And that was just 1 month post the passing of my father, who was afflicted with pretty widespread metastatic disease and sadly succumbed just after 3 months. But today, CRAN has proudly become a national, non-for-profit, patient-focused advocacy group wherein we're governed by an experienced board of directors, we're counseled by an expert medical and scientific advisory board, and at CRAN, we have not one, but 2 patient advisory councils, one of which, by the way, is dedicated to the under 50 patient population whose past experiences with the disease help to inform our patient program development to ensure our services are relevant and meaningful. In terms of our mandate, we champion the health and the well-being of Canadians touched by colorectal cancer and others who are at risk of developing the disease. And we do this by providing support, education, and advocacy to patients and their caregivers to help improve patients' quality of life as well as their longevity. But of particular relevance for today's talk, CRAN has expanded its patient-focused mandate to now be serving multiple tumor type patients through our HTA patient evidence submissions, for example, through our educational events and scientific conferences, our advocacy initiatives, and now our patient programming to ultimately reduce the burden of cancer in Canada, and that's actually our mission. So why? Why, as a patient organization, do we have a rather robust mandate dedicated to advancing biomarker testing? Everything that we do at CRAN is inspired by patients and the challenges and the barriers they experience throughout their journeys informs our work. And over the years, we've heard from patients such as Matthew, appearing on the left, the biomarker testing results are not being delivered in a timely manner to help inform clinical decisions. In Matthew's case, it took 5 months for his biomarker testing results to come back to help inform his treatment plan. And increasingly, we're also hearing from patients such as Robin, appearing on the right, who are keen to have their tumor's biomarker profile comprehensively assessed so that they may feel empowered to thoroughly explore every potential treatment option with their treating oncologist that may be available to them. And in Robin's case, CGP identified an actionable mutation, an HRD, for which she received a targeted treatment for her metastatic colorectal cancer, which, by the way, significantly and meaningfully improved her quality of life and also extended the very precious time she was able to spend with her family before her passing. Metastatic cancer patients across tumor types have been contacting us and other patient groups to request information and assistance with respect to accessing CGP, as well as relaying that biomarker testing results are not being delivered by the time they meet with their treating oncologist to help inform critically important treatment decisions. This requires advocacy efforts on the part of the patient groups. So essentially, it's all about the patient who helps drive change. But soliciting change can be a tricky thing. As humans, we're often resistant to change, and this is one of the hurdles we are presented with in our advocacy work. So if we lean on some principles of change management for a moment here, we know that in order to elicit any kind of change, we first need to build an awareness of the issue or the issues, and secondly, we need to build the desire to create that much needed change. Now, enhancing access to biomarker testing and the precision medicines is a complex, multifactorial issue. And to make an impact, we need to have diverse stakeholders at the table, as many diverse stakeholders at the table. I myself and my colleagues are true believers in the power of collaboration. And by collaborating with and working with as many stakeholders, as many experts, as many patient groups as possible, I truly believe we can more effectively build that awareness and that desire that is required to solicit change. So before I get into CRAN's CGP project, I want to take a moment to speak to our second biomarkers conference hosted back in June of 2024, which was widely supported by the patient group community. 24 patient groups, actually, as highlighted on the left of the slide, as well as diverse stakeholders who participated in that conference. Leading experts engaged in very thoughtful discussions throughout the conference, and the outcomes included 2 calls to action, which were developed and disseminated throughout our post-conference publication, appearing in Current Oncology, and they included 1, improving access to publicly funded CGP for all patients with advanced and metastatic cancer, and 2, developing and implementing national standards for the performance, the integration, coordination, and communication of biomarker testing. Once the June 2024 conference was completed, together with a medical oncologist and a patient in each respective province, we met with ministries of health and key policy professionals in Alberta, Manitoba, Saskatchewan, Newfoundland, British Columbia, and Ontario to share the outcomes of our conference series on behalf of our patient group partners. It's been a rather successful start to the advocacy campaign, opening the door to allow us to build that awareness and that desire for change of which I spoke earlier, which are truly the prerequisites to change. But I have to share with you, ladies and gentlemen, that through those meetings, CRAN was able to identify a missing link, something that policymakers were looking for that I just could not provide, because the evidence simply did not exist in the Canadian context. That missing link was the economic piece to support the introduction of comprehensive genomic profiling into the cancer care landscape. So the next step in our advocacy work was to lead a study to evaluate the costs and benefits of funding universal CGP across Canada for 5 stage 4 cancers: lung, colorectal, pancreas, breast, and prostate, versus the current standard of care, to determine if CGP could become the new standard of care in Canada for all de novo metastatic cancer patients in Canada. And while this may have been ambitious, and it was, We truly believe that every health policy advancement in, in, in Canada must start with a bold and ambitious vision, and CRAN was prepared to lead that charge. So once we made a commitment to lead that charge, a little over a year ago, CRAN commissioned the Conference Board of Canada to model and analyze the cost and benefits of universal CGP versus the current standard of care across the top 5 cancers based on mortality rates in the de novo metastatic setting. Those 5 cancers: lung, colorectal, pancreatic, breast, and prostate cancers account for approximately 60% of deaths in Canada, which is precisely why they were chosen. The current standard of care was modeled to be a 50-50 split of CGP and point mutational testing, as was recommended by our expert reviewers, which is reflective of the inconsistencies with publicly funded testing across our great country currently. The costs and benefits were modeled and analyzed over a 6-year time horizon from 2025 to 2030 to capture both current and emerging technologies. The analysis has taken on a societal perspective. It looked specifically at the implementation of CGP in the Canadian context, and it offers key insights that we believe will be quite helpful in shaping future policy development. Now, the implications of this project extend well beyond the 5 identified cancers, and we plan to continue to generate compelling evidence by exploring provincial level real-world data and examining how the findings can be extrapolated and applied in additional tumor types through the next phase of our work, which is currently under development. The initial findings of the CGP cost and benefit analysis were delivered as the keynote presentation at CRAN's 2025 Biomarkers Conference last June, which focused on the future of genomic testing in the Canadian healthcare landscape. And the final report was released just a couple of months ago in both English and French, and we are quite proud. These are the 18 wonderful patient groups who stand in solidarity with our vision for this research project and beyond. We are incredibly thankful for their support, and I feel honored to be able to share this information on behalf of these groups and CRAN. You'll notice that CHCC is there. Brenda has been extremely supportive, not only with respect to this project, but has also participated in our scientific conferences, such as the Biomarkers Conferences and Early Age Onset Cancer Symposia. And thank you, Brenda. Thank you. In the modeling, the costs that were assessed included treatment costs, which, not surprisingly, account for the majority of the costs, gene panel costs, inclusive of bench costs, overhead, analysis, and storage. There were costs associated with delayed care. These are the validated costs associated with turnaround time, for example, and costs associated with hospitalizations, surgeries, physician services, other diagnostic testing and prescription drug costs, home and community care services, and alternative testing costs, which were applied to patients with unsuccessful CGP results, which I think accounted for approximately 10%. 2 primary benefits were modeled: life years gained, which was derived by the higher rates of identifying actionable biomarkers and receiving the matched therapies, and societal contributions assessed by total income linked to improved survival when patients are able to avail themselves of an additional line of targeted therapy. I am so pleased to report that study findings were indeed quite compelling and positive across all 5 tumor types. I'll start with the benefits. Most importantly, the analysis found that 3,440 life years would be gained across the 5 tumor types. This and this alone should be reason enough to move forward with CGP throughout Canada, but it most certainly does get better. The analysis found that $180 million would be gained in societal economic contribution through an increase in total income linked to improved survival. The economic contributions captures not only direct employment income, but other contributions such as investment income, private retirement income, employment insurance, and so forth and so on. And when the costs were calculated, it turned out that there wasn't a cost incurred at all, but rather a potential savings to the healthcare system. The modeling demonstrated that universal CGP could actually save the healthcare system money to the tune of $87 million to $134 million over the 6-year time horizon. Additionally, costs are expected to further decrease and savings and benefits further increase as CGP and precision medicine evolve, and indeed, they do intend to evolve. The cost and benefit analysis has demonstrated that universal CGP for patients diagnosed with metastatic cancer in Canada can result in significant survival benefits for these patients at decreased healthcare system cost compared to the current standard of care. And to our knowledge, this is the first data generated modeling the costs and the benefits of universal CGP in the Canadian healthcare system. And as we continue to dig just a little further, overall, we know that lung, colorectal, pancreas, breast, and prostate cancers account for close to 60% of Canadian cancer mortality. Due to the many nuances of tumor subtypes and extensive treatment lines for lung, pancreatic, and breast cancers, those 3, researchers decided to focus on just the stage 4 subtypes with the highest prevalence. So with respect to lung cancer, for example, only metastatic non-small cell lung cancer was modeled because it accounts for approximately 87% of metastatic lung cancer cases. And for the same reason, only metastatic pancreatic ductal adenocarcinoma, which accounts for 90% of pancreatic cancer cases, was modeled. And the same for metastatic invasive ductal carcinoma, which accounts for 80% of breast cancer cases. Colorectal and prostate cancers, however, were modeled as single diseases. The findings were positive across all 5 tumor types, as the slide clearly demonstrates. This data is extremely encouraging and hopeful. And from the perspective of the patient, which should drive all health policy decisions, in my very humble opinion, CGP is a clear win. In looking at this slide, the focus is on lung cancer. Positive values, highlighted in green, indicate a cost savings to the healthcare system. As you can see, depending on the type of gene panel utilized, if CGP were universally adopted for metastatic lung cancer, we see significant system-level savings. These values were modeled conservatively, I might add, and are likely underestimated. Not only could universal access to CGP save lives, but it could also save the healthcare system resources and money. We believe this economic case is critical to advancing policy change. Now, it's easy to look at this slide and focus a little more on the green at the right, where 161 gene panel was modeled, but I'd like to highlight that even with a larger gene panel size, in this case, a 324 gene panel appearing on the left. When we look at cost per patient, it's essentially cost neutral. How, you might ask? In the setting of hundreds of thousands of dollars spent on therapeutics, on treatments, this $131 cost per patient is barely a drop in the bucket, and testing is estimated to account for only 0.3 to 4.1% of the overall cost per patient. So we're all acutely aware that precision oncology is a rapidly evolving field. We are dealing with a moving target here, and it is critical that a strong position be adopted with respect to CGP so the Canadian patients are not disadvantaged. Patients value information and options. And if we focus on adopting smaller gene panels, we risk building recommendations which will be outdated by the time they can be implemented. I won't go through the minutiae of each tumor type, but we see similar positive results in colorectal cancer, as you can see from this slide, in pancreatic cancer, in breast cancer, and in prostate cancer. All 5 tumor types that were modeled had positive and compelling results. Now, we can't possibly rest our laurels on what has been generated to date, but this is a great start. And we, with our patient group partners, will continue with our national collaborative biomarker advocacy campaign to present these compelling findings to provincial ministries of health and decision makers across the country. We will do so with the assistance of medical oncologists, the Conference Board of Canada, who has played such an instrumental role in generating the results. And of course, we will have a patient representative present in every province with us because they drive everything we do at CRAN. And of course, we will proceed to phase 2 of our project to amass additional findings to add to the body of evidence to support the introduction of CGP in the Canadian cancer care landscape. We're just waiting for our publication to appear in print, which should appear in print within the next month or so. CRAN's Pan-Tumor Biomarkers Conference Series has certainly evolved over the years, from identifying barriers and challenges to molecular testing and results, to proceeding towards a national strategy for advancing CGP in metastatic cancer care in 2026. Our 2025 Biomarkers Conference outcomes will be published, much as I've already alluded to, in approximately a month or so, and that publication will contain the CGP cost and benefit analysis findings to kick off our 2026 conference. And we truly hope to see you all there virtually, and that will essentially serve as the basis for the meetings we hope to host with the ministries of health, provincial ministries of health across the country. And finally, together with our patient advocacy partners and the support of all stakeholders, we are working towards 1, reducing turnaround time for biomarker testing and results across tumor types, and 2, providing equitable access to comprehensive genomic profiling for metastatic cancer patients in Canada. But our voice is stronger, ladies and gentlemen, together. And on behalf of CRAN, I invite you to stand with us. Thank you for your attention today. I'm providing the QR code to the actual CGP report that was generated that contains all the necessary information you may wish to access post-presentation. I'm really pleased to have been here today. And for you tuning in, I'm happy to answer any questions you may have. I'll stop sharing.
Thank you, Filomena. That was a wonderful, wonderful presentation.